This instruction will introduce the ACLS tachyarrhythmia protocol. Make the preliminary diagnosis. A wide complex tachycardia is defined as a rapid rhythm, generally 150 beats per minute or more when attributable to an arrhythmia. A wide complex tachycardia can be regular or irregularly irregular and have uniform, monomorphic, or differing, polymorphic QRS complexes from beat to beat. The patient is unstable. Blood pressure is 70/40, the rate is 180 beats per minute, and saturation is 92% with an oxygen mask. The patient complains of chest pain and has decreased mental status. Unstable patients require immediate electric cardioversion. Give synchronized shock. If the patient continues to be unstable, you need to increase the energy level for the next cardioversion, add an antiarrhythmic drug, or briefly have a consultation with other experts. If the patient was stabilized after aftershock, but still has a wide complex tachycardia of 150 beats per minute, give an appropriate antiarrhythmic drug. First dose of adenosine will be 6 mg and the second dose will be 12 mg. Give only if wide complex tachycardia is regular and monomorphic. Administration of 4-amiodarone, procainamide, or sotalol may be considered for the treatment of wide complex tachycardia. Adenosine should not be administered for hemodynamically unstable, irregularly irregular, or polymorphic wide complex tachycardias. After giving amiodarone and procainamide, patient still have tachyarrhythmia of 150 beats per minute but QRS less than 0.12 seconds. Make the preliminary diagnosis in ECG and monitor. There is narrow complex tachycardia. Narrow complex tachycardia represents a range of tachyarrhythmias originating from a circuit or focus involving the atria or the AV node. Clinicians must determine if the tachycardia is narrow complex or wide complex tachycardia and if it has a regular or irregular rhythm. Blood pressure is 70/40, the rate is 180 beats per minute, and saturation is 92% with an oxygen mask. The patient complains of chest pain and has decreased mental status. Unstable patients require immediate electric cardioversion. Give synchronized shock. Make the preliminary diagnosis in ECG and monitor again. The diagnosis of atrial fibrillation. Give synchronized shock 120 J biphasic. The patient was stabilized aftershock but still has a narrow complex tachycardia of 150 beats per minute. Do vagal maneuvers and give appropriate antiarrhythmic drugs. Success rates for the Valsalva maneuver in terminating SVT range from 19% to 54%. Augmenting the Valsalva maneuver with passive leg raise is more effective. Given the potential thromboembolic risk, caution is advised when deploying carotid massage in older patients. The modified Valsalva maneuver can be used to help treat tachycardia. To perform the modified Valsalva maneuver, instruct the patient to take a deep breath, then exhale slowly and evenly against resistance for about 15 seconds. This can be repeated a few times as needed to try to slow the heart rate. It is important to note that the modified Valsalva maneuver should only be performed under the guidance of a healthcare professional.